After the shoulder has been reduced or put into its socket, though, there's really one major question that you need to ask yourself. Hello and welcome to the Shoulder and Arm Health channel. I'm Dr. Roger Sohn. I'm a board-certified orthopedic surgeon. In today's video, I'm going to talk to you about the latest advancements in shoulder dislocation and instability care. Specifically, I'm going to be talking about a condition called anterior shoulder instability, which is the most common type of instability. I'm going to also be talking about the chance of a recurrence or another dislocation after the first dislocation, and I'll also talk about a major problem that is associated with surgery and how newer implants are helping to solve this problem. A shoulder dislocation is a true emergency. If you are lucky enough to have an athletic trainer or other trained personnel who are nearby when your shoulder dislocates, they may be able to help you put it back into the socket. Often though, someone who dislocates their shoulder will have to go to the emergency room to receive sedation and have expert care where the shoulder will be put back into the socket. That's called a reduction. After the shoulder has been reduced or put into its socket though, there's really one major question that you need to ask yourself. And that important question is, what are the chances that my shoulder will dislocate another time? We call that recurrence risk. Aside from the obvious inconvenience of having the shoulder dislocate, as well as the pain that is associated with it, dislocations are a big deal. Why? Because every time the shoulder dislocates, there is damage done. The most common form of damage is something called a Bankart lesion. As the ball of the ball and socket joint dislocates, it pulls on several ligaments that are attached to the socket in a rim called the labrum. When the front of that rim tears off and pulls away from the bone, that creates a weak spot called a Bankart lesion. Because of this weak spot, the ball no longer has the same restraint to a further dislocation, leading to the risk that this will happen again. In most cases, this Bankart lesion will not heal on its own. Now, in more severe cases, the labrum or the ligament damage will take with it a chip of bone, and that is called a bony Bankart lesion. This can range from a very tiny fleck of bone all the way up to a large percentage of the joint that gets broken off. Each time the shoulder dislocates, it has the potential to create larger and larger defects in the rim and in the bone. This damage is done to the socket, but if you look at the actual other side, the humeral head or the ball of the ball and socket joint, that can receive damage as well. Each time that the ball dislocates out the front of the shoulder, it ends up in the front of the socket, and therefore the socket can leave a dent or an indentation on the back of the humeral head. That's called a Hill-Sachs lesion. Now, if you can picture it in your mind, if the socket is getting smaller because of the growing bony Bankart lesion, and if the ball is also getting smaller because of the growing Hill-Sachs lesion, that leaves less of an arc of motion where the two can safely rotate without having another dislocation. So all of this adds up to a more and more unstable joint that is more prone to dislocations. Now, dislocations are one thing, but the surfaces that we're talking about are cartilage-covered surfaces. Cartilage is a precious resource, and when it gets damaged, it's not coming back. As the cartilage gets more and more damaged, it makes people prone to having something called arthritis. Now, arthritis is a painful condition where the cartilage wears away and that leaves bare bone surfaces. It's usually an older person's disease affecting people in their 60s and beyond. But in people who've had a dislocation, this can start becoming a real problem as people enter their 30s. So the most important thing we can do is to prevent future dislocations. What are the chances that my shoulder will dislocate another time? It depends on your age at the time of your first dislocation. If you're under the age of 20, the risk of another dislocation is more than 80%. Some reports have said that if you are 18 or under, the risk is virtually 100% that it will happen again. Between the ages of 20 and 30, the risk drops slightly to between 75 and 80%. And if you're over the age of 50, the risk is fairly manageable at between 15 and 20%. This may have something to do with the activities that younger people do. It also might have something to do with the amount of force it takes to damage younger and healthier tissue, meaning that younger people who dislocate their shoulder generally have a higher force of impact when that shoulder dislocates. So depending on your age, it may be quite reasonable to choose not to do a surgery to repair your shoulder, especially if you're in your 50s or 60s the first time the shoulder dislocates. For those of my patients who choose not to do a surgery, I generally send them through a course of physical therapy where they train their subscapularis and get that as strong as possible. In addition, they will be working on their shoulder blade stabilizers. The shoulder blade is very important for shoulder stability. In fact, there's one of the maneuvers we do called the shoulder blade rotation maneuver that helps us to actually reduce the shoulder in an acute setting when the shoulder has dislocated. So the importance of shoulder blade stability cannot be underemphasized. For many patients though, the risk of another dislocation is high enough that they choose to have a surgery to help reduce the risk. It is important that you and your doctor both understand the nature and severity of your shoulder injury. The type of surgery depends on the type of injury that you have. In my practice, almost any unstable shoulder will be treated arthroscopically. That means we use a fiber optic camera system to look inside the joint that allows us to see in high definition the amount and severity of the damage to the cartilage and to the rim. It also helps us to see the damage to the bone, such as the Hill-Sachs lesion and the bony Bankart lesion we discussed previously. In many cases, we can place suture tapes and anchors around the torn tissue, and then we can anchor them to the bone using a special technique. This allows multiple anchors to be placed from multiple angles without having to make a large incision on the shoulder. In more severe cases where there's a large Hill-Sachs lesion, which is that dent on the back of the humeral head that we talked about, we have to do something called a remplissage procedure, where we take some of the nearby tissue called the infraspinatus tendon and we tack it into the dented humeral head. That creates a restraint mechanism so that as the shoulder rotates into the position of danger, that it actually acts as a seatbelt and stops the shoulder from rotating too far. In other cases, we can transfer a nearby tendon called the long head of the biceps tendon and pass it through the subscapularis tendon, creating a dynamic sling that gets tighter as the shoulder approaches a position of danger. Now, in cases where we have critical bone loss, meaning there's more than 15% of the socket that is damaged, we need to do something to build back the socket. In those cases, we usually do what's called a ladder J procedure. And a ladder J procedure involves taking the nearby conjoint tendon and the attached bone called the coracoid process, and we pass that through a split in the subscapularis tendon. This allows us to build up a larger surface to support the humeral head. In addition, it has a sling effect. When the shoulder goes up into a position of danger where it might dislocate, the strap muscles that are attached to that bone block get tighter, and therefore it's a dynamic mechanism. Here is some video from our website showing how we do the ladder J procedure completely arthroscopically. Through various surgical portals, we're able to transfer the coracoid through the subscapularis muscle and to the area where the bone is missing. We secure it there with either screws or a suture button. So not only are we adding additional bone surface area, we're also adding a dynamic restraint which helps the shoulder to be stable even in extreme positions. The risk of another dislocation after having surgery goes down significantly. If done properly, the risk of another dislocation may be as low as 4% and all the way up to about 10%. Although surgery can be so helpful at reducing the risk of another dislocation, long-term there are some concerns. Some studies have shown that patients who have had dislocations and then a surgery to fix the dislocations, the risk of forming arthritis is higher than in the general population. People have suggested various explanations for this. Maybe it was the injury of the dislocation itself that caused the die to be cast, and as a result the shoulder was destined to have arthritis anyway. Others have actually postulated that maybe it's the surgery itself. We do know that anchors that use sutures, and specifically sutures that have to be tied into knots, are more likely to cause abrasions on the cartilage of the humerus and surrounding bone. Most of the implants of today do not require any knots to be tied. They're called knotless technology. What that usually means is that we place the suture material around the torn structure, and then we pound in an anchor which holds the suture material in by friction. That allows us to leave no tail or no knots whatsoever. Because these sutures are very low profile, the body can cover them with something called synovium, leading to a much lower risk of knot-related friction. So if your shoulder is unstable, please don't just watch my video. Make sure you understand your risk of another dislocation. Go see an orthopedic surgeon, someone who specializes in shoulders, and I'm sure they will be able to help you prevent future dislocations. Please hit the like button, and if you'd like to learn more about shoulder and arm health, hit the subscribe button.